All right. And then since we're recording now, I'm going to introduce myself again. Hello, my name is Jesse Suter. I use he, him pronouns, and I'm the director of the Center on Disability and Community Inclusion at the University of Vermont. I am a white man in my late 40s, wearing a dark blue button-up shirt in front of a green virtual background with the website of our project, which is go.uvm.edu/SCOPE-VT. It's my pleasure to introduce our main presenter today. Tammy Leombrono works for the Vermont Child Health Training Partnership. She comes to the training partnership from the private practice sector as a psychotherapist, consultant, trainer, evaluator, and clinical supervisor specializing in trauma-informed practice. She's provided various clinical services in a variety of settings, including children's residential, the state correctional facility, and community mental health. Tammy established the New England Counseling and Trauma Associates in November.
Jesse, I made a mistake. I unmute you by mistake again. I'm admitting people and then.
Okay.
Perfect.
So what was the last thing people heard?
I think just the last two sentences.
Oh, okay. So hi again. I'm not sure if this is rehashing or not, but Tammy, you established the New England Counseling and Trauma Associates in November 2005 as a private practice designed to specialize in the assessment and treatment of children and families impacted by trauma. In her 26 years of practice, she's worked with hundreds of families and has had the opportunity to collaborate with various child-serving agencies across the state. And Tammy has a special interest in working with children and youth with problematic sexual behavior and has developed a specialized treatment curriculum for this population. I'm pleased to welcome Tammy and thank you for presenting today.
Okay, thank you, Jesse. So I'll give a description. So hi, everyone, I'm Tammy, and I have short hair and I have funky glasses on. Someone told me I look like Billie Jean King, so whatever that is, with orange and stuff, and a striped shirt and hoop earrings. And I'm in an office with a light, kind of a lilac background. So thank you and welcome, everybody. Okay, so we are going to be talking a bit about trauma-exposed children. And again, the title, A Primer on Impact, Trauma-Related Responses and Intervention. And as someone who's been doing this work a long time, and it's like, oh my gosh, I have to squeeze this down into 25 minutes, which, so it's an overview that I certainly hope is helpful for folks. Okay. Oh, I can't see Sarah, but thank you, Sarah. So hoping today to just kind of get a better understanding of how trauma and traumatic stress is defined for kids, increased understanding of how traumatic stress impacts children and youth, become familiar with at least a few of the evidence-based interventions that are out there, and to get a little bit more of an understanding of trauma-informed care. And we will be talking about trauma-informed interventions along the way. Okay, oh, sorry, next slide, please. Sorry. So there is, the DSM, which is the Diagnostic and Statistical Manual, which lists all the mental health. It's the kind of the cookbook for the mental health diagnoses. Has a definition that is not exactly on the slide because it seems like it's really targeted more towards young adults and adults. So this, I'm trying to have it geared a little bit more towards kids. So a traumatic event for a child or youth, it's frightening, dangerous, could be violent event that either literally is harming a child, threatening a child or youth's life or their integrity, and certainly witnessing a traumatic event that does the same to a loved one is considered and can be traumatic. And for kids, that happens often. They don't have to be the direct victim. We certainly know that traumatic events can lead to strong emotions, physical reactions, all kinds of different emotions. Physiologically, kids can experience, here it is like a racing heart and heartbeat and sweaty, and they may be sick. And they may just feel incredible energy. They don't know what to do in their bodies. They might also feel what kind of looks like the opposite, which is a freeze, essentially a freeze response, where kids are shut down and disconnected. And we know that that is a really common response for younger children. In terms of talking about trauma today, I mean, there will be some words that I'm using in phrases. So trauma, traumatic stress, toxic stress, we hear regular kind of trauma word, we hear complex trauma, developmental trauma. So today, I'll probably use the term trauma mostly, but just understand that sometimes they are used interchangeably. And it's just important to know, so when a child or youth experiences traumatic stress, the reactions they have in their experience, it just impacts them and can interfere with their day-to-day kind of functioning and their ability to relate to others. So we're going to be talking about that quite a bit. And essentially, it's important to remember, I think the hallmark of doing some of this trauma work is recognizing that these situations, it overwhelms kids' ability to cope. Okay, next slide, please. Okay, so a traumatic experience can be a one-time experience, or it can be ongoing. Sometimes we refer to the one-time experience as a single incident trauma. I know it can tell you that in terms of treatment, sometimes that is easier. I don't know if that's the right word, or more manageable, but a one-time experience could be a car crash, physical assault, witnessing something violent in the community, a natural disaster, you're in, a storm, I don't know, fire is kind of a natural disaster. So that is going to be a one-time experience, or it's ongoing. And when it's ongoing, it's typically in the family setting or the community setting. So certainly living in an unsafe community, experiencing hands-on abuse, so sexual or physical abuse, living in a home with extreme conflict or violence. Thank you. Okay, so things that can be traumatic for children and youth. This is not an exhaustive or comprehensive list, but just try to hit on as many as I could. And people, if they wanted to type in a chat and say, oh, you forgot this one, please feel free. So folks are probably, when they hear trauma, I imagine you think physical abuse, sexual abuse, neglect, maybe emotional or psychological abuse. We certainly know parental separation, divorce. Then there's also that kids being separated from caregivers. So disruptions in the attachment system, disruptions in caregivers, different placements, systemic racism for sure, sudden or violent loss of a loved one, family violence, accidents. So all kinds of accidents, illness itself, and then certainly medical procedures or invasive medical procedures. Again, community violence, refugee and war experience, historical trauma. So again, this multi-generational groups of folks experiencing this kind of trauma, caregiver, substance abuse, mental illness, certainly military, family-related stressors, natural disasters. And again, I'm sure there are things, I know there are things that aren't on this list, but I'm certainly happy to add some for future trainings if folks want to do that. Okay, and bullying, for example, is another one that should be on there probably. Next slide, please. So this is just a slide I put together that kind of, in doing collages or other work with kids over the years, sometimes I think it's important to get a visual of what it might be like. So this isn't necessarily what a child or teen might do, but it's just kind of what I was finding and put those together, all kinds of violence and emergency, and hopefully that's covering the different domains. Okay, next, please. So generally speaking, children and youth who have experienced trauma, and I should have said earlier the term adversity too, I should have said that, they oftentimes develop and have this expectation that bad things will happen to them. And it's something that's sitting with kids. For me, it was in a therapy role or as an evaluator. It's really quite striking sometimes. And so, for kids who are old enough to articulate it, they may just be able to say things like that people say, oh, they're negative, or they always think this is going to happen. But it kind of comes from, this place of early experiences that have been negative or harmful. In terms of, little babies or toddlers, maybe we'll see something like that in terms of being startled by something, they're not sure what's going on, or maybe their affect, the way they express emotions is kind of all over the place. So also we know that children and youth have a hard time, who have been impacted by trauma, have a hard time forming relationships. And this seems to make really good sense, understanding that a lot of the adversity, the trauma, these events, they happen within the family setting, within those primary relationships. So you can imagine as kids get older, or even outside of the home, or even within the home, it's so hard to navigate, figure these things out, and to have trust in relationships. So this is quite common. And certainly the experience about feelings and emotions and behaviors. And I'm imagining that folks, in whatever your roles are, your jobs are, maybe you hear about kids, they can't regulate, they're acting out, or they're always angry, or they're sad, or they're all over the place. It's really hard for kids to kind of say or be able to explain or even understand what's going on sometimes to them internally. We know that a lot of times, if they didn't have that with those early primary relationships, didn't have that kind of give and take, the reciprocity, someone echoing something back, a caregiver and a child having that, it's really hard for them to do it. They misinterpret and don't know. There could be caregivers who are inconsistent or impaired. So this is a really big one, and we'll hear this throughout the presentation. And then the other thing that's really big for kids who have been impacted by trauma is just this, they just don't necessarily have a positive sense of themselves. And it's going to look different over different developmental stages, but just may have negative self-image. They certainly already have that expectation that bad things might happen. They're not necessarily future oriented. And it's really hard when you see a kid who just, they just can't see past kind of the moment. So it's stuff that it's really workable, but it's really hard to kind of see and sit with sometimes. Okay, next slide, please. So, I had used the phrase act out a lot of times in my experience, and this could be with schools or daycares or preschools or after school programs. A lot of I happen to, maybe know the child they're talking about, but a lot of times the behavioral, so the outward behavioral or the emotional presentation is categorized as in this negative way, or it's like, they're hyperactive, they're moving, they're aggressive, they're acting out. A lot of times I say to folks when I supervise them, or if I'm in meetings, like, I think that's what we call a trauma-related behavior or trauma-related response. And I think it's important to kind of shift that language when we can. So trauma-related responses are patterns or these repetitive routines, and they just play themselves out in the relationship and environment with kids kind of over and over again. And certainly caregivers or other providers can get frustrated with that. Language, one last little note on this, is the language we use with kids and when talking about these kids is really important. Okay. Next slide. Thank you. So reactions in children may include, as I kind of said earlier, intense and ongoing emotional upset, may be described as mood swings again, or hyperactive, or they're so sensitive, these kids, they're always angry. We don't know, they seem to be overreacting to something that wasn't a big deal. It could include depressive symptoms or symptoms of anxiety. Kids with trauma certainly have, kids in general have fears and worries. Kids who have been impacted by trauma, especially if it's ongoing, have a lot of worries and fears. Again, behavioral changes, that could be a number of different things. It's, maybe if they were kind of quiet, maybe they're not so quiet. If they used to be maybe more outgoing, they're a little bit more withdrawn. Maybe there does seem to be an increase in frustration tolerance or issues kind of getting along with other kids and navigating those relationships. Here it is again, the difficulties with self-regulation. We know there's a physiological component to that. You know, when kids' brains are activated and their bodies are activated and they're in a fear response, that regulating is really hard. Again, we'll talk more about that. Certainly here it is, the problems relating to others. So the interpersonal stuff seems to be really tricky for most kids. It doesn't have to be in every setting, but certainly is hard. It's hard for them. It's so hard for kids to navigate. You know, picking up other folks. How are other people feeling? They don't really know that. How are they're responding to me? Are they mad at me? Are they upset with me? False alarms go off in kids and they react as if they're in some sort of danger or an unsafe situation. There's the whole part about regression or loss of previously acquired skills. That could be, you know, toileting for a younger child. You know, they had mastered toileting and suddenly there are accidents and things happen. It could be language seems to be changing. It could be other skills that maybe kids had some more independence and suddenly there seems to be a shift in that. Let's see, attention and academic difficulties. So certainly attention, you know, we know that kids, people probably have heard fight, flight, or freeze. You know, if they're activated or worried about something or have fears or just aren't sure if someone's upset with them, it's really hard to pay attention, right? It's hard to say, oh, wait, I'm in class and I need to listen and do this work. This isn't terribly conscious for them, but they're kind of somewhere else. You know, we kind of say this front brain, the prefrontal cortex, where kind of the thinking and the problem solving is happening, but kids might be kind of in the other part of their brain, kind of in that survival mode. So they miss a lot. Certainly nighttime routines, nighttime falling asleep, waking up at night are frequent kind of problems and issues. Kids may be able to fall asleep, but they wake a lot. There could be nightmares, night terrors. We're also going to want to, you know, check in about kids eating, you know, other kinds of things. But certainly sleep and nighttime is a big deal. And then certainly physical symptoms. So aches and pains, headaches, stomach aches, kids with low energy. You know, you may hear if you're on a team or a caregiver or whatever your role is that, wow, this child is always low energy, or they fall asleep, or they're always saying they don't feel well. So we want to pay attention to that. It's not that, you know, if we just took like one of these bullet points, that doesn't mean that a child has experienced trauma, right? It's typically a constellation of symptoms. We're going to kind of look at that. And then certainly if we know that there have been some insults or adversities for kids, we may be able to look for this. Okay, next slide, please. So kind of moving into the therapeutic part of this, we're going to talk a little bit, and go right to the next slide, about how can we support trauma impacted kids. And so the NCTSN that you see on the slide is a wonderful resource, great website, everything, well, not everything, most everything is free. You can download, put it into a PDF, such great information. So I just want to put a little plug in there. And I'm sure that's in the resources at the end. So ways in which we can support kids impacted by trauma. This could be primary caregiver, extended family member, someone at school, a daycare provider, another care provider, after school, a coach. It doesn't have to just be the primary caregiver. But one of the ways is we can educate ourselves about, hey, what are the common responses and reactions that kids who have experienced trauma, you know, what are those? What do they look like? And so if we know what they look like, we may not have to, you know, have a strong reaction to them ourselves. I mean, we need to normalize those in some ways. Like, hey, oh, these kids might be a little more hesitant to, I don't know, approach a new situation. They may be a little more, this particular assignment in class may be a little bit harder for this child, or, you know, on any number of things. So again, if we educate ourselves, normalize some of those responses, that's going to be really helpful. To the extent that we can assure children about their safety, let's do it. You know, we can't always, like, let's say it's a child lives in a violent community or a community where there's a lot of upheaval. We can't control that, but we can certainly try to nail down some specific ways in which we as the adults are going to help a child to feel safe. I was thinking of another example of a family I worked with who had needed to flee home because there was significant violence, and you know, and it's like, you can't be 100% sure that this other caregiver is not going to find them or hurt them in the future, but you can certainly say, here's what we're doing today, here's where we're staying, this is what we're going to do to make you feel safe. So assurance is certainly helpful. Reassure kids and teens that this isn't their fault, kind of whatever that this is. Even though it might be obvious, that you may say, well, this child had nothing to do with this adult in the home being hit or this other thing that happened. They were on the other end of being sexually maltreated or abused. And yeah, it's important that we kind of remind kids about that. And when we can, we say it's not your fault. Provide space for kids to talk about or draw or play out sometime, or if you pull that out of them a little bit, what are their worries and fears? How are they feeling? And sometimes it's hard as the caregiver to kind of ask for that, because it's hard to hold because we feel so worried and scared and sad and upset about and for our children. But if we give them some space, that's really great. I talk a lot about containment. If we can help kids contain some of this stuff, and sometimes as the primary caregiver, that's going to be one of our major jobs. Okay, what else got here? So maintain routines. Oh, routines are so important. So predictability, routine, and structure really is helpful to young children, but also to school-age children and even teens. And that helps kind of keep kids grounded and I think focused and present and engaged. And even if you're in a different place and you've had to move, try to keep this is around the time we eat dinner. This is what we do at bedtime. This is what we do on the weekends, whatever that is. So that would be important. Try to be patient and understanding that healing might look different for children than what we think in our heads. It also may take more time. We also may be like, oh gosh, I think we're doing okay. We've rounded a corner, and there could be a little backsliding. So just trying to be aware of that. And then certainly consulting with mental health folks if it seems like that needs to happen. That could happen through your doctor's office. It could happen if there is some sort of investigation with some sort of physical abuse or sexual abuse or neglect. Could be the investigative units at, there's CUSI, NUSI, I don't know all the names, or an advocate, victim advocate. And if I didn't say it before, schools can also do that. Okay, next slide, please. Okay. So this slide is talking about when and how is it that kids begin to heal and what helps. And so we're going back to, there's this theme, right? Relationship. So kind of like thinking about those early relationships with infants and toddlers with their caregivers and how important that is in terms of literal, physical, cognitive, language, social, emotional development. So it is with healing. So we want these to encourage, whenever we can, strong positive relationships with a primary caregiver. It doesn't have to be a parent, but certainly can be. Support can be from other family members, extended family members, school folks. If it's younger kids, again, daycare, preschool, after-school program. A community could be a faith-based or religious connection, friends. We know that kids can heal when they feel safe, and safety across settings. A lot of times safety tends when things are we hope the safety is starting at home because that's when kids are at home. So we want that to happen, but that it will generalize to the community, to school. Sometimes kids who are impacted and have anxiety they don't want to be separated from the caregiver. So that's something we have to work on. Certainly a sense of belonging and affiliation. This is really getting at resiliency. If we want kids to stay in communities, stay in their homes whenever possible. If again, back to they belong to an organization or it's the school, we want kids in the same school. And there's I think it's the ESSA, other people on the call will probably know, but just the priority about keeping kids in the schools that they're in. If they need to move to a kinship placement or a foster placement, the goal is to keep them there. We know that kids need access to basic resources, food, clothing, shelter, kindness, care. Access to, I'm jumping for a minute, but access to trauma-informed services. So that could be counseling, it could be in school, could be in the community, Certainly medical services, anything that's related to housing, if they need help, the family needs help with navigating the legal system. In terms of kind of meaning in one's life and a sense of themselves in the future, those are a little bit more advanced concepts and constructs. And so that might be a little more geared in terms of interventions, kind of more overtly with some of our older school-aged and then middle-aged kids, middle school, excuse me, and high school. But it is really important when kids have a sense of themselves in the future and thinking or wondering and being curious about who they can be. And we'll talk a little bit more about identity in a minute. So I think that's enough on that slide. So Bruce Perry, I'm sure a lot of folks have heard of him. He's, experts in the field of attachment and trauma and all that kind of jazz. And he and Oprah, that interview is amazing and the book is great. So a quote from him: so the more healthy relationships a child has, the more likely they will be able to recover from trauma and thrive. Relationships are the agents of change, and the most powerful therapy is human love. And we can move on, but again, that's speaking to connection, relationship. The power of that cannot be understated in terms of helping kids, supporting kids through trauma and kids who have experienced trauma. Okay, so in terms of the interventions, I'm not going to be able, I'm just peeking at the time here. Oh, I'll get moving. We're not going to go into a lot of detail, but we're just going to talk about a couple models. There are some that I looked up, and I can give Jesse or Sarah this handout I created of child-specific trauma interventions, but some geared for children, so from birth on. And a lot of those treatments interventions involve the family and are actually done in the home, but they're really great. So they're not going to get a big shout out here. Attachment regulation and competency is, it's called the ARC model. We were lucky enough in the state several years ago, all the DAs, and then NFI, and then our practice, it was a pretty big group, got to be for a year and a half up to 2 years, ongoing training and consultation on the model. It is developed for kids, so kids and adolescents who have experienced complex trauma and their caregiving systems, which is really the best part of this model, is kids and the caregiving system. It was built on, and incorporates aspects: normative child development, traumatic stress, attachment, risk, and resilience, which is obviously very important. And the overarching goal is to support families, right? Just to be together and to have safe, healthy relationships. I like that it's quite a model, but I like that feels pretty clear to me what the goal is. And it really is a very practical, generalizable, usable, I don't know if that's a word in that way, model. So from birth to young adults and kids who have a range of presentation in terms of their developmental and cognitive profile. And it can be used in different settings. So the primary care setting, like biological family, kin, foster, can be used in the therapeutic milieu, group home, and also in organizations with schools or after school programs. So it's quite wonderful. It's trauma sensitive and trauma informed. Okay, next slide. I'm going to keep cruising here. Sorry. So this is, so these are the three major domains. So attachment, regulation, competency, and the attachment piece. I love that the whole onus isn't kind of just on like kids and kids have to attach. It's really talking more about the interaction of the child and caregiver and child. So it works to the model. The work is supporting the caregivers and recognizing their reactions, thoughts, feelings, emotions, what they bring to the relationship and how they need to navigate, manage, and then also for the kids and kind of the combination of the two. So the goals are to enhance connection, rhythm, which is so important, and reciprocity, kind of that exchange, and help build effective trauma-informed responses to the kids and teens, either their own children, foster kin, and also for folks who can use this in residential programs too. So the regulation, again, enhancing child and caregiver awareness and identifying, understanding, tolerating, which is big. Affect tolerance is a very big it's really important. And we need to do a lot of work on that, because if we can't tolerate the emotions coming from us, or if our children can't tolerate it coming that we're putting onto them, then it keeps us really stuck in helping to manage. So we just want them to understand it more. They do a lot of practice and increase, again, that tolerance of intense feelings, because we know that these kids have them. And so do the caregivers. And again, so it's about relational connection. So competency is really helping youth, the kids and teens, to explore aspects of themselves and their identity and who they are and who they want to be. And it's future oriented, and it's also building a coherent narrative about even all kind of the bad stuff that happened and the good, and to give themselves permission to kind of look towards the future, to increase a sense of agency, and to kind of come to peace with all of it, honoring their history and moving forward. Okay. Next one. So the next slide is about, maybe it's freezing. Oh, there it is, thanks. So it's trauma-focused cognitive behavioral therapy, TFCBT, which folks may be familiar with. It's one of the most researched, most often researched, that's not a great sentence, in terms of trauma and trauma in kids. So it is, sorry, the overview. So you are, I apologize, I'm getting caught up in my own slides here. The goal is to reduce traumatic stress symptoms, improve overall functioning and development of kids and adolescents with a history of exposure, as you can see here. So it's used with kids and youth to 21, so 3 to 21. A lot of similar concepts in terms of the treatment. So regulating the feelings, the affect, behavior, focus on a little bit on relationships, trauma processing, enhancing safety. And there is a focus on parenting skills and family communication. There's a ton of information about TFCBT. There are several variations of that with different names that I won't mention now, but yes, so there it is. So that's what we'll say about TFCBT. Moving right along. So trauma-informed care, which is what I mentioned earlier, is what hopefully, I'm hoping in your different, wherever you are, wherever you work, your organizations or agencies, you're talking about that. I'm going to start with the bottom first, which is from the ARC model. So a trauma-informed organization is one in which every member of the organization, child, parent, provider, feels safe, supported, and empowered. And its approach to engaging people with histories of trauma that recognizes the importance of trauma symptoms and acknowledges the role that has played in their lives. So it's just kind of putting on this lens and understanding people in a different way. It also involves a fair amount of training, because ideally everyone in your organization gets some level of training about trauma-informed care and delivery of services. And it's very similar to what we're asking caregivers to do. So get some training, get some information, understand what the common responses and reactions to trauma are. Be supportive, validate, provide safety, all that kind of jazz. Okay, and I think in this state, we are moving in the right direction, which is really nice. I think folks have bought into that. Okay, and we're cruising, wrapping up here with our last slide. So 4 principles of trauma-informed care. So a little bit of a restatement, but realizing the widespread impact of trauma and understanding, which is important, the pathways for recovery, kind of recognizing, being familiar with signs and symptoms of trauma, not only in clients, but with families, with staff, coworkers, others involved in the system. Respond by integrating the knowledge, what do we know? What do we still need to learn in terms of information we need to get in policies, procedures, and practices? And certainly we want to resist any re-traumatization of children and their caregivers when we're doing this work. And those are adapted from SAMHSA. Okay, so I was peeking at the time. Okay, so that is kind of it. Oh, I should say that there, it says there's a thumbnail, there will be a list of resources and other links, I believe. Okay, we'll take a drink here. Do we have questions, or how do folks want to proceed? Comments?
This is Jesse. Tammy, thank you. Thank you so much. You're doing great. And yes, this is the time to see if there's any questions that folks may have for Tammy. I don't see anything in chat. So you can raise your virtual hand or you can type something in the chat. And they're coming in. So Tammy, let me read them for you since I'm taking a look at it. So the first is, Tammy, are you still in private practice? Do you by chance do consults with professionals?
I am, oh, you're gonna love this answer. I'm kind of not in private practice. I do work here full-time at UVM. I'm a consultant at NCSS, a clinical consultant, and I'll probably in some time do a little bit more, just a very part-time consults, open up a practice specifically just for consulting on trauma and abuse cases. Thanks for asking. And
from Laura Ryan, what type of therapy is recommended for children with pre-verbal trauma?
Oh, good question. So this is what I wish I had sent to you folks, so I apologize. There are, if you go on the nctsn.org website, this is where you can find a list about child-specific trauma interventions. And there are several that are for, again, from birth through age 6. It's in the home, and it seems like so some of this obviously will be nonverbal. I think in those cases, a lot of times it would be great. And when we have young children, we really need to be including the family. Like there's no other way around it, really. If it's the biological family, kinship, foster, adoptive, we have to bring them in. So they're going to have to just use, if it's nonverbal or pre-verbal, use other strategies. So some of them might tune into more art, also just kind of trying to get a clear sense of what the history is in terms of documentation. So you'd want that. And you really would want to find someone who has some expertise and specialty, which might be tricky. I might recommend trying the CDC, so the Child Development Clinic, to start there, or start with your doctor's office to maybe try to get some referrals. Or if other people have ideas, jump in, please.
This is Jesse. I'm not jumping in. I'm just going to see if there's any other questions. But if somebody does want to jump in, please feel free. Sarah, I see you spelled out the acronym for NCTSN in chat. That's the National Child Traumatic Stress Network. Thank you.